stress that we're nonpartisan and that we work collaboratively to ensure that all Marylanders have the health care they need and deserve. So if you're actually presenting as a coalition member, I also stress that that we, although we have women in our name, that we really use the voice of women to get health care for all and don't focus solely on women's health issues, and that we work very strategically in the areas of policy and legislation, as well as outreach and doing educational programs like this. So if there's anybody in the audience who would like to have such a presentation, be sure to let us know. And then obviously we also do advocacy, and we encourage others, individuals and organizations, to join us, because the more voices we have and the more diverse those voices are, the more power we have in advancing our agenda. So, and the actual objectives for today are to put the Affordable Care Act in context. All too many people have forgotten what the health care landscape looked like before the Affordable Care Act passed. So we'll talk about that a bit, talk about the promise of the Affordable Care Act, and specifically look at the patient protection, the access for coverage and for care, talk about the specifics of the way Maryland is implementing it, and then give people some resources where they can go. And I see that a couple more people have joined, so this is a very informal presentation by me. So for those who have joined, stop me and ask questions, particularly if there are things you don't understand or I'm not clear about, so that we can be sure to correct those in the future. I also always say when I do presentations that I don't know anything, and I rely upon a lot of other smarter people to get the answers. So if there are questions that can't be answered here, that we can always come back to people and provide them with more information. So it just doesn't like to advance with the forward key. Can you explain that, Sandy?
Well, go down to the bottom left and do it that way. Yeah, there you go.
Okay. So we're not there yet. The Commonwealth Fund came out with a really useful study. So everybody knows one of the favorite provisions of the Affordable Care Act is the coverage for young adults without insurance up to age 26. So we've made advances in that area, but nearly half of adults spent part of the year without coverage, or were underinsured, which is something we don't talk about very often, but in fact that was a key factor in people going into bankruptcy or losing their houses in the past. And so other areas where we still need to make advancements, lower income adults are uninsured and underinsured at much higher rates. So 75% at the 133% of federal poverty level, which is about $15,000 for a single person, about $22,000 for a family of 4. And we're still at 59% for that next category, the 133 to 249% of federal poverty. And we know that millions of people are struggling to pay their medical bills because the premiums are too high and co-pays are too high. So those are some of the things that will be addressed in the Affordable Care Act. And we know that many women, for instance, go without mammograms because they can't afford to pay for them. So 43% have cost-related problems getting care, which continues to rise, and hopefully will be part of what's addressed with the Affordable Care Act. So in Maryland, the number of uninsured is about 730,000. That breaks down to 56% men and 44% women. And of those women categories, those figures are the percentages. So we know that racial and ethnic minorities are particularly impacted by being uninsured. And we also know that insurance carriers in the past have discriminated against women, charging us more simply because we're a woman, or denying us, so that saying that the National Women's Law Center came up with, which everybody and their grandmother has now adopted, which being a woman is no longer a pre-existing condition is one of the benefits of the Affordable Care Act. So I like to start out by just talking first to make the Affordable Care Act, all 2,000-plus pages of it, understandable, to break out the patient protection parts of it, and then talk about the affordability. And because health equity is such a high priority for the coalition, and of course it's high on the agenda for the exchange, which we're grateful for, to wrap all of this within the goal of creating health equity, because there's so many pieces to the Affordable Care Act that really leverage that possibility. And in part, the non-discrimination for gender, race, ethnicity, sexual orientation, and gender identity are really key components that are new under the Affordable Care Act, and that parity for behavioral and somatic health care is another great opportunity, as are the strong preventive care services that are provided under the Act. So, sorry, my dog has just decided that she would like to help advance the slides by coming up on my desk. So what are some of the patient's protections in what's known as the Patient Bill of Rights? So we talked about the young adults staying on their parents' health plan until the age of 26. So when they come out of college and they can't find a job, at least we know they're going to have health coverage. A really key component, and it's great that Chuck Milligan at Medicaid really has pushed this, is that foster youth are now eligible to stay on Medicaid up until the age of 26. And his point is that the state are their parents, and they should have the same opportunities that those of us lucky enough to have parents have an opportunity to have. So the seniors get help with the closing of the donut hole, so that'll be complete by 2020. They already have been getting dollars back to help them pay for their prescription drugs. No longer can insurance carriers put lifetime or annual limits on our care, so halfway through our treatment for cancer, they can't say, oh, by the way, you've just maxed out, too bad, go home. We don't need a pre-authorization if we're on our way to the ER, so, if I'm headed to Sibley Hospital, I don't have to call my carrier and say, do I need a pre-authorization, and they say yes, and then I end up at some other hospital I don't want to be at. They can't take away our insurance without a real cause. And one of the patient protections that went into place early was that no pre-existing exclusions for children. So two of the Maryland stories that HHS and President Obama use are about AV and Jax. AV with leukemia diagnosed at the age of 3, and Jax born with a genetic heart condition with his heart on the wrong side of his chest and his intestines turned upside down. Those children, their parents didn't need to worry about whether they could afford their care, and when they reach adulthood, they're not going to have to worry that they can't get insurance at all. So, these are just absolutely critical. And I think that the way the Affordable Care Act was framed was very clever in putting in these Patient Bill of Rights first, because the next piece of it, which is the affordability piece, of course, is about to kick in and several years after the law passed. But one of the pieces, when we focus on the women's aspect of it, is the piece that we have to thank Senator Mikulski for, which is the Women's Health Amendment, so that the preventive services that are key are now accessible without a copay or deductible. So remember when I said I think it's 37% of women can't access mammograms because they couldn't afford them. That will no longer be the case. We now get a well woman visit without a copay, breastfeeding support. So a mom I was having lunch with the other day who just had her second child was going to be able to go get a new breast pump without a copay. Family planning services, including contraception, are now available without a copay, and we should remember that under the old system, only 39% of policies in the individual market covered family planning and maternity care. So some women would become pregnant and assume their insurance would cover them, and it didn't, so we can all imagine what that looked like. That is no longer the case. These provisions went in last August. We have screenings for HIV, STI, and domestic violence, all new, and also HPV testing. So huge advances for women in these preventive services. So now let's look at the affordability piece of that. Everybody gets in other words, everybody gets access to health care. And when I say that, we have to make the proviso that, of course, undocumented immigrants are not eligible under the ACA, so they're still going to have to get their services through safety net clinics and others. And hopefully we will be addressing that down the road. And the coalition did do with Lee Cobb at ACY, did a handout on immigrants and the provisions around them. So that's available for anybody who wants it. There is also that personal responsibility piece, which is what the Supreme Court decision was about almost exactly 1 year ago today. And so that basically was upheld by the Supreme Court. But if you, in fact, require people to purchase insurance, then you have to make it affordable. And so let's turn to that piece. So first of all, for Medicaid, it expands Medicaid to 130, we're going to say 138%. It's 133 in the law, but there's a 5% differential. So it really brings us up to 138% of federal poverty. So about $15,282 for an individual and $31,322 for a family of four. And when all the states were debating whether they should expand Medicaid, and we know that some of them are still debating this, Chuck Milligan in the Medicaid office said, why would we turn down all those federal dollars? Because we get 100% federal funding for the new expansion population, and that goes down to 90% in 2017. So we're still getting a big chunk of change from the feds. And then there'll be the eligibility determination and the enrollment, and then they'll go into managed care organizations. And the enrollment projections, you can see there 108,000 going into Medicaid in 2014. That's assuming that all of the outreach and enrollment works well, and by 2020 getting 187,000 in. A part of the population that's moving into Medicaid are those that are currently in the primary adult care program right now. That was set up for adults without dependent children with minimal benefits, and they will automatically enroll in Medicaid. They'll just seamlessly move over in January of 2014. So the state has a real push now to get people, eligible individuals, enrolled in PAC right now that aren't there now. So you'll see that rolling out soon at a shop near you, as I like to say. In determining eligibility, they'll use the new process of the modified adjustment gross income calculation, which is much simpler, and it will align the eligibility determinations between Medicaid and the qualified health plans sold in the exchange. So the process should be a lot cleaner and more expeditious. Sorry, I lost my mouse. So for those then who are between 138 and 400% of federal poverty, which for a family of four takes you up to $94,200, they are going to be eligible for advanced premium tax credits, which will help them pay for the qualified health plans that are going to be sold through Maryland Health Connection, which we'll talk about in a minute. And there is, remember the personal responsibility piece, there's a requirement that everybody purchase insurance. There's a very small penalty if you don't purchase insurance. It's only $95. And one of the big pushes is to be to make sure that the, in quotes, young invincible, though between 21 and 35, do have insurance, because you all know that we need those healthy folks in the risk pool as well as the higher risk individuals. And I don't have it on a slide, I don't think, but the Maryland high-risk pool and the federal high-risk pool that we have in Maryland, they're going to gradually move those people into the exchange. They don't want to put them all in the exchange at one time because obviously that would weight it too heavily and would drive the price of the insurance premiums up. So they're going to be looking at this very carefully. Any questions so far? Anything not clear? Okay. So this chart from the exchange shows what the financial assistance piece looks like. And I like to tell this story, and I was interested yesterday at the materials that were rolled out with a sample from Consumers Union. They used a story to illustrate the impact of this, and I had a story thanks to my hairdresser the other day, which also raises the issue that while most of what the exchange talks about is getting the uninsured in, that in fact the new Maryland Health Connection site allows the opportunity for individuals who currently have insurance to go there and see if in fact they're eligible for the new advanced premium tax credits to help them pay for their insurance, or to compare their plan and see if in fact there's something better on the exchange. So I was at my hairdresser's, and she, for some reason, seems to trust me on all issues, including health care, and she said that her premiums had just risen by 15%, and she thought she'd have to drop her insurance. And I said, oh, my gosh, don't do that. Hang in there, because in October you and I are going to sit down at a computer and figure out if you're eligible for these advanced premium tax credits that will help you pay. So she told me her income level was $25,000. So I went to Kaiser's subsidy calculator, and I mistyped in the notes. I mistyped the hyperlink to that. It's subsidy with a Y, not an E. But anyway, I went in and looked, and in fact, she will get a tax credit subsidy equal to 44% of the premium cost. So she's going to save a big chunk of change by going into the exchange and getting one of these subsidies. And let me just say as a caveat to you guys, somebody just said to me yesterday that Kaiser calculator was done some time ago and may not be completely accurate. So, nobody should go in there today and then come out in 4 months and say, oh, my gosh, that said something than what I really got. But it does give people a feeling for the opportunity that will be presented to them in the future. So small businesses, too, are affected by the affordability piece. So they get tax credits for those with 25 or fewer full-time equivalent employees and with an average wage of $50,000. And nonprofits will also benefit from this tax credit. They get a refundable tax credit up to 25% on their premiums. Maryland already has a small business tax credit, so businesses are actually eligible for this today, and that will go up 10% for 2014 and 2015. This tax credit does expire in 2016, and so it's important that we get as many small businesses as possible in at the start to make sure that they take advantage of this. So, sorry, was there a question? Okay. So now I want to talk a little bit about Maryland and what we've done here, because we have every reason to be proud of what our state has accomplished to date, albeit while we may be lucky to live in Maryland, it's a real challenge for all of us on this call who are working on this issue. So as we know, Maryland had already expanded the eligibility level for Medicaid to 116% for families or parents with dependent children some years ago, and then they were hoped to expand and in fact passed a statute expanding access for adults without dependent children, and there was never the funding to do that. So the ACA opens up this opportunity again. So the day after the president signed the Affordable Care Act, Governor O'Malley turned right around and signed an executive order setting up the Health Care Reform Coordinating Council, which was charged with putting together the roadmap for implementation. And one of their first tasks was to create the basis for the first exchange legislation in 2011, which set up the Maryland Health Benefit Exchange, and also put in place the Medicaid expansion, which actually technically went into statute this year. And so what does it mean for Maryland to be in the lead? Because we really are. So I like to say now it's a wild ride. And we're flying the plane as we're building it, and we may all be smiling in that plane in that picture, but oh my gosh, we're totally exhausted. So one of the things that has been difficult, I think, is the very challenging and aggressive timeline for implementation for us to meet the October 1, 2013 opening for open enrollment. And I think that all of us on this call probably took heart last year as we waited for the Supreme Court decision, and when the Lieutenant Governor was asked by the press what Maryland would do if the Supreme Court went against us, and he said, we will not slow down, we will not delay. So that kept us on this wild ride, which brought in $157 million in federal dollars, and that supported our work in multiple areas. A lot of it's gone into the implementation and the setting up of the Health Benefit Exchange, and a big part of that is the IT systems that Mary Lou's been working on. Some of that's gone into the community health centers and into other areas. And I say that we're creating a national model because as we're flying this plane and building it at the same time, all the other states and the feds are watching to see where we're putting the engine in the wheels. Because when our exchange folks go in to talk to the feds, they bring everybody in from all the other departments to see what we're doing and what decisions they're making. So for the advocates and those of us working on the ground and the exchange staff and the administration, what it means is obviously that we have to get it right. So we've had 3 pieces of legislation, as you know, the most recent one in 2013 that made sure we were in line with the federal statute and also with the regulations that have come down. And throughout the legislative process, the administration has had a really positive, constructive, inclusive, transparent process that meant all those stakeholder advisory groups that all of you sat on or participated in one form or another, and also a very open process with, let me take that back and say with the legislation, what they did was to bring together the stakeholders to take a draft bill and refine that through the amendment process so that when the final bill went to the floor of the House and the Senate, all of the stakeholders had a sense of ownership in the final product. And while, you know, the consumer advocacy community didn't get everything we wanted, we really felt that our voices were heard and in many cases heeded, and we got substantive consumer protections and other pieces into our legislation. So I think Maryland in many ways has the best legislation in the country. For the policy piece of it with the work of the Exchange Board, the coalition and our partners all had people sitting on each of those committees, and I like to say that we made all the members keep their cell phones on so we could text them with questions during the process. So in 2013, actually I guess in 2012, the Exchange started a producer advisory council, and then we also got in legislation this year, very important, a standing advisory committee for the Exchange Board that will ramp up in March of next year. So right now, the Exchange does not have any active advisory committees, which is something we're hoping to do something about, particularly in regards to the Navigator program. So where are people going to go to find out what they're eligible for, whether it's the advanced premium tax credit or the Medicaid? Everybody's going to go through the state-based exchange. We're one of only 17 states that are doing a state-based exchange, and that is really important because it means that we end up with something that works for our residents, and we're not getting the federal exchange, good as I'm sure it's going to be. That's not going to be dropped down in our state and made to work. So people will go there. They'll be able to find out what they're eligible for, and they'll be able to select their plans based on costs that will include both premium and copay. So they'll be able to figure out what the real cost of these plans is going to be. They'll be able to determine, make their decisions based on the performance of the plans on some specific quality measures, an area that the coalition is weighing in on, and also on ratings by quality and price. So, and as you all have heard me say thousands of times, so they're going to be able to compare those plans apples to apples, and if they can't decide when they're in the Apple aisle if they like the Fuji or the Rome better, they're going to have real live people to help them. So there'll be the website, Maryland Health Connection. There'll be a consolidated services call center, telephone helpline, and then there'll be the navigators. And I'm going to talk about those more. So, but the key dates are the Maryland Health Connection is the public face of the Maryland Health Benefit Exchange. So when I talk about the Maryland Health Benefit Exchange, that's the governance and administrative piece of it, and Maryland Health Connection is the public site. And it opens officially for enrollment purposes on October 1st of this year, and then on January 1st, 2014, people will start to get the benefits from the qualified health plan. And I put in here the website link to a video, which is basically the one that you can also find on HHS that describes for consumers what the Health Benefit Exchange is. So, and that MarylandHealthConnection.gov site is up at the moment. It's basically a placeholder right now, but it'll be going live, I think, in late June or July, fully live, I think. So when you go there, the Medicaid benefits are going to remain the same as they are today. And for those between 138 and 400% of federal poverty, they'll go into the qualified health plans. And it's important for people to know that the only place they're going to get the advanced premium tax credit is if they go to Maryland Health Connection. If you buy a plan outside of the exchange, you do not get the advanced premium tax credit. So, but the qualified health plans will be sold both inside and outside the exchange. And they have to meet what is called the essential health benefit. And there was a complicated process set up by HHS to determine what that was. And the Healthcare Reform Coordinating Council made the decision to go with Maryland's largest small group plan, which is a Care First Blue Choice plan. And so that's an open formulary, no prescription drug exemptions, and it has to cover ambulatory patient services, emergency services, hospitalization, maternity, and newborn. And remember, I said that in the past only 39% of individual plans covered maternity care. So people are getting more today than they did in the past. And that's an important point to make. When I do presentations, people say, well, they may be more expensive or blah-de-blah-de-blah-de, but I think we need to make sure people understand these are more comprehensive plans than they have been able to buy in the past. So in the past, if you had an insurance plan that didn't have maternity care, you had to buy a rider to get that. So it also covers prescription drugs, lab services, mental health and substance use disorder services, and for those in the essential health benefit for Maryland, they brought in the benefit from the federal plan, and that one has got to be parity compliant, and that is really important. So then rehabilitative and habilitative services, the preventive and wellness services, and again, a key thing about these ACA people need to understand is the emphasis on prevention, because if we get to the prevention piece, we will begin to drive down the cost of health care. And the last piece is pediatric oral, and dental. And I don't think Lee is on the call because she would be stamping her foot and saying we have some concerns about the pediatric benefits. So that's something we're going to be continuing to track. But that is an essential health benefit under this plan. So the plans have been submitted to the Maryland Insurance Commissioner. This is another reason we're lucky in Maryland because our insurance commissioner has the statutory authority to review these plans and to make sure that they are compliant and that their rates are not out of line with what they should be. And they have to make sure that they have an adequate number of providers in each of the carriers' networks and that they have to include mental health and substance use disorder providers, that's the MHSUD, and they have to contract with essential community providers, which are defined by the federal government, and something we're trying to get, we're trying to expand that definition for Maryland. That's one of the many areas that we'll be working on in the future. But I did put in the notes for this a link that provides a list of those essential community providers in Maryland if anybody wants to track that down. It has to comply with the Federal Parity Act, and it has to have continuity of care provisions. So we know that when the exchange opens, these carriers will be selling plans in the exchange. Plans will be sold at 4 metal levels that are based on their actuarial values, so platinum, gold, silver, and bronze. And each of the carriers are allowed to sell 4 plans for each level. So that means 16 plans per carrier. So you can multiply that out, and that's one heck of a lot of plans. So it shows how important it is that on the IT systems that they are set up in a way that consumers are going to be able to easily compare the plans. And then there are 10 that are going to be selling standalone dental. We always get the question about adult dental not being in the essential health benefit package, and that is true, but Maryland is looking into being able to provide that in the future. So how are we going to make sure that people are going to get access to their insurance card? So to help them through that maze takes outreach, and education, and then getting them through the enrollment process. And then, you know, we've been talking about the culture of health in Maryland, so getting the card alone is not enough. We have got to make sure that they get the right providers and that they have continuity of care, because one of the issues we're concerned about is when there is the potential for churn, as it's called. So if people's income moves above 138%, they become eligible for the advanced premium tax credits, and they could move out of Medicaid and their managed care organization into a qualified health plan with a different provider network. So this year in statute, we got in some sections to deal with the continuity of care piece. So in Maryland, what we've done is set up the Connector program that is going to have working under it certified navigators, which I'll talk about a little more in a minute, and assisters, and then the Consolidated Services Call Center will also be under the exchange, and others who can sell will be the brokers and insurance producers who are selling today, and they'll be selling in that small business exchange. So Maryland will have an individual exchange and an exchange for small businesses. And then there will also be folks called the Certified Application Counselors, and they are individuals in local health departments and hospitals who are already doing this kind of eligibility and enrollment today. So they will not be paid through the exchange. And then there's a new category that got put in this year. We just love this one, called Captive Producers, and it's exactly what it sounds like. It's producers who are held captive by their insurance company. They work for a specific insurance carrier, and they sell their products. And we wanted some stringent controls on these because we want to make sure that they don't just say to people when they're, come up for renewal, oh, listen, you can just continue to enroll in Aetna's, HBO plan. We want to make sure that consumers know that they can go to the exchange and see if, in fact, they're eligible for something more. So we did get, fortunately, a sunset provision on that one. So Maryland went through 2 navigator advisory processes, both of which were co-chaired by Lee Cobb, so we know they came up with the best ideas possible. And they divided the state into 6 regions, and they just, in late April, released the contracts for the entities that are going to be in charge. They're going to be the single point of contact for outreach and education in these different regions around the state. So I just thought this might be of interest to show how race and ethnicity break down across the different regions and what the uninsured numbers look like. And the allocation of the dollars for these navigator entities was based upon the number of uninsured in these counties. So the navigators, the general training areas are a general knowledge of the Affordable Care Act and a picture of the uninsured in Maryland, a working knowledge of the new HICS, that's the Health Exchange's IT interface, and we've been told that for navigators, training for that alone will be about 40 hours. And then they'll also be learning about cultural competency and health literacy, and it's at this point, of course, that I push the cultural competency and health literacy webinar we're going to be holding on June 24th, which is going to focus specifically on the connector entity piece. They also need to know about the medical assistance programs, the advanced premium tax credits, and the qualified health plan selection. So we like to bring everything back to the thought that all of this leverages the opportunities for really creating health equity in the state, reducing the health disparities. So we do that by accessing affordable and culturally appropriate care. Another piece of it that I think the coalition is going to be working on a lot more is the idea that we really need health literate consumers, that I would argue most people aren't health literate consumers, even if they've had health insurance for a very long time, and surely not the uninsured who may not know what it means to go to a primary care provider for the first time and what kinds of questions to ask. And then we're also looking at a number of state initiatives, the state health improvement process, and the great work that's being done by local health action coalitions like those in Prince George's County, as Barbara Guest and Madeline are on, that they are participating in that. Then I'm sure you all know about the Health Enterprise Zone, and I think there's one of those in Prince George's County as well, to leverage dollars to improve access to care there. And then there's a new state innovation model project underway, a community integrated medical home. So one of the coalition's initiatives is to ensure that all of these initiatives and all of the work going on at the exchange are fully integrated so that at the end of the day we actually do get closer to health equity, if not there in the end. So reform doesn't end on January 1st, 2014, although I just heard last night at the CCIO is going to be closing down its EHB office, which I can't imagine why they would be doing that, since the Secretary of Health and Human Services is going to reevaluate the EHB in a year and determine if changes should be made. But anyway, some of the areas that we're going to be looking at are that reduction of disparities. Is it working? Are people getting access to a card and to care? Network adequacy. Are the provider networks actually, are they sufficient for this new population that's coming in? Can we get the definition of essential community providers expanded so that, for instance, school-based health care centers could be considered under this? Ensuring that the continuity of care provisions go fully into effect and that they work. looking at the impact of churn, what's happening to that population as they move from 138 to 139%. And one of the populations we're really looking closely at are pregnant women, because Maryland covers pregnant women in Medicaid up to 250% of federal poverty. So if a woman becomes pregnant and her income is between 138 and 250% of federal poverty, she becomes eligible for Medicaid, which obviously would cost less, and she'd get dental coverage. So, but she would then move from her qualified health plan into Medicaid through 60 days postpartum, and then she would move back into her QHP, assuming her income didn't go down below 138%. So there are a lot of problems to look for in all of that process, and women have to self-identify for this. So we'll be looking at that. We'll be looking at the access to culturally appropriate care. Is that really happening? We're going to be looking at the affordability piece. I mean, I know we're all concerned about, are these plans going to be affordable, particularly for the 138 to 200 to 50% of federal poverty, and are they parity compliant? Adrienne Ellis on our steering committee is going to keep us on task there. So, and then obviously, encourage everybody to join the coalition because of all of our great resources. And we always encourage people to share their stories because that's the most effective way to let people know about the advantages of the Affordable Care Act. And I think it's really important to remember that we are going to have to show whether this is not working, but we're also going to have to show that it is working if we want to continue to build support for the ACA, and more importantly, if we want to get people enrolled in the exchange. So then just some resources that people can go to, but we really encourage them to go to our website where there are a lot more resources. Mm-hmm. So that whole thing took about 40 minutes without any stopping for questions, which is, I probably put more slides in there than I would for a sort of a, I'll say, normal presentation. So, questions? You're numb? You're wondering why you're listening to this at all? Or you hung up on me?
I'm still here.
I know, Sandy. You just can't.
Hi, Lenny. It's Barbara.
Hi, Barbara.
Barbara's on.
That was a really good presentation, and yes, it is a little mind-numbing. I'm still getting used to the terminology and the relationships of the plans to the population. But I think that one of the things that's going to need a very, from what I heard from Sarah Rosenbaum a while back, the issue of churning and the issue of people going on and off Medicaid based on their income, and when that comes in and how people are affected, I think is something that will have to be very carefully explained, because it looks like people can really run into financial trouble and get financial penalties without understanding why, if you know what I mean.
Yeah, well, so they will go in to the advanced premium tax credit. One thing that's useful to remember as we think about the continuity of care and tracking what's happening to people is that when people enroll through the exchange, they will each get a unique identifying number. Mm-hmm. And the Medicaid population all have a unique identifying number. We want to make sure that there's correlation between those two. But the exchange will have the opportunity through the IT systems, particularly as they get to phases 2 and 3 of those IT systems, to keep track of this. They're also collecting data in a lot of areas. And, Barbara, this is an area that we want to make sure they're collecting the right data. So, because that data is going to be important as we analyze the continuity of care piece. Mm-hmm. As I say, there are some pieces in statute about that continuity of care and what does and does not have to be pre-authorized and how long that transfer is, and carriers had a say in that. We did fight for those continuity of care provisions to be required as of January 2014, and we didn't win that one. It's January 2015, but they will be tracking that, but they won't be doing a report until 2017. So, I mean, I think your point is really well taken also on the affordability piece. Thinking about the messaging piece of this when we're talking about it with the public, I think it's important not to oversell this, but at the same time, not to get people too worried at the outset. You know what I mean? I mean, I think there's a delicate,
I do.
Yeah. A delicate balancing act.
I agree.
Yeah. So, and I think our job is, I was just developing a list of issues that we're, fuller list of issues we're going to be tracking over the next 2 years, and I mean, there are masses of them. We're going to need a lot of people to help us with this.
Mm-hmm.
But this is Sandy. I mean, as far as giving the message to people that you're going to have financial security when you get health coverage, and then they are worrying about their changing income levels and how is that going to affect them. I mean, it's all really complicated with, IRS tax rules and how it's going to work with the exchange and what they can expect. And this is going to be a major portion of the training of the navigators. And Lenny, would you agree with this comment that we don't have a clear understanding of exactly how that's really going to work?
That's an understatement.
Yeah. So, I mean, I think right now we have to just assure them that there's going to be a lot of people who are trained to make sure that hopefully people will, be okay. They'll be protected. They'll not have these churn issues that affect them in a bad way.
Right.
And I think we have to keep our very close eye on how it will work so that we can be saying the right message to people. And in fact, we just got this new communication toolkit from the exchange yesterday. I haven't had a chance to look at it completely, but I do think they have some messaging that they say they've tested around financial issues, I think. I don't know, Lenny, have you taken a look at some of those fact sheets on that?
I haven't. I was just pulling that up.
I can't So I think we have to kind of hone in on that because I agree, Barbara. I mean, we've heard it from Deborah. We've heard it from other people. These questions about how will they be impacted financially, if they know their income might change, and each case is going to be different. We're going to have an answer for that. And I don't think we have exactly the answer right now. It may be you're going to have to talk to a navigator, but I think there's going to be a lot of information out there to help consumers become more aware as well. Hopefully it'll be good.
So one thing you touched lightly, Sandy, but I think it's worth reiterating, and I think you were on this call and not me, but the fact that the financial security that's probably the best-selling message. And I remember a year ago that messaging was discussed as being particularly strong for men, but I think so applies for women. Right, Sandy? Was that not right?
Financial security, protection against, for your family, this type of thing.
The other thing too, Sandy, and I am now up on the you get to the toolkit through the new outreach tab. What they don't have there, and what they showed yesterday, was a brochure put together by Consumers Union. And I actually have to email the gal that gave that presentation about something else. I'm going to ask her if she and I talked about whether Consumers Union would be putting together a Quest Q&A, and they're starting something, and I think they did something comprehensive. And is May Che on the call?
Yes, I am.
Hi, May.
Hi.
So everybody, this is May Che, and May and I and Mary Lou had been talking about May helping to put something like that together for the coalition. So I'm going to track back with the Gallup Consumers Union and see what they're putting together so that we could see what the coalition might want to get up on our website. But if any of you are out doing these presentations, getting questions, it's really helpful. The questions that we get when we do these are different from what the exchange folks get because they're not talking to the people on the ground the way we are. So, Barbara, when you're doing stuff in Cheverly and so forth, if you can send us those questions of concern, I think that would just help us and the exchange folks enormously.
Sure, will do.
Okay. So I will track down that Consumers Union brochure because Sandy, I think you agree that was really useful.
Yeah.
Yeah. Okay. If you all, when you're thinking about this, or if any of you actually do this presentation or something like it, and you think there are any changes that need to be made, as I say, this is kind of next week I have to do one actually that's 2 hours long, so heaven knows what I'm going to add to that. But, often, and May actually has been at my Obamacare house parties, which don't have a PowerPoint at all. I just, I do all these points and just talk about them without visuals. But this is kind of a longer version. And I think that as we get to the point at which the connector entities really begin to get their navigator programs in place, there'll probably be a lot more emphasis on that. And, for those of us in Montgomery and Prince George's County, getting materials, I hope, from the Montgomery County Department of Health and Human Services, which is our connector entity, or Cheryl up in Baltimore getting them from Healthcare Access Maryland, to get this, specific regional material will be very important. So, anything else for now?
I didn't know whether I could download. I can print this out, the webinar that you just did, right?
Yeah, and Sandy, I think you just sent it around to everybody.
Yeah, I think she did.
So I sent you the PowerPoint file, Barbara, and we are recording the webinar, so Zenobia can post that on our website later in case you want to hear it again later.
Okay, great. Thank you.
Okay, and also just if you're interested, up on the website on the left-hand side, there is one of our presentations, and the one we actually put up was one I did earlier this year with Adrienne Ellis of the Mental Health Association of Maryland for the National Association of Social Workers, and that has a big chunk on the whole parity piece, mental health and so forth. So there's some slides in there that you can use.
Okay.
And then the resources that the exchange just put up, as Sandy I think said at the beginning, that has slides you can also pull in if you want to sort of personalize this.
Right, and I would add that in a couple of cases when we had more time, we showed a Kaiser Family Foundation video that tells you what is a marketplace, what is this exchange concept, and the Maryland Health Connection now has a little short, pretty short video that says the same thing, and it's customized to Maryland. So it could be, if you're in a room with Wi-Fi, you can use that as a sort of a different media thing to show people in addition to the PowerPoint.
Yeah, because the exchanges one is really, I'm just going to say, pretty lightweight for consumers. There's a Kaiser one and then another one.
Commonwealth Fund.
The Commonwealth Fund is really, I think, a little more highbrow, so for a different audience. But there are some great videos. And then last week when we did a program in Howard County during the registration period, we actually showed the president in the little blue room at the White House when he was surrounded by people impacted by the Affordable Care Act, including two of our Maryland storytellers. One, Alicia, with her daughter Avi, was He actually called it Alicia Care. So there are resources up there, that you can use that are not just based on our PowerPoint. So, as I said, I'm not sure, Barbara, if you'd gotten on by then, but if you all are doing presentations and using the coalition's resources, it would be great if you could let Sandy or me know, because we really like to keep track of, how these are being used, the coalition's resources are being used, in part so we can tell our funders and they will give us even more money.
Thank you.
Well, listen, thank you, everybody. I appreciate your taking the time, and you know where to find us if you need us.